Hi, this is David Villar, and welcome to this presentation on general considerations of non-steroidal anti-inflammatory drugs. If in previous videos we already talked about the inflammation, and one of the things that we said is that it's a very complex process which has many chemical mediators involved, not just the prostaglandins that are the ones suppressed by non-steroidal anti-inflammatory drugs. Why do I tell you this? Well, in pharmacology there are two categories of drugs that fall into the lucky ones of being called as anti-inflammatory drugs, and these are actually the glucocorticosteroids and the NSAIDs. And however, the truly anti-inflammatory ones are really the glucocorticoids because they block the production of the arachidonic acid early in the cascade of the inflammatory process, and by doing so they actually block too many other pathways like the leukotrienes that are a really big one, and actually they block many of the functions of the white blood cells, whereas for example the NSAID actually what they do is suppress the prostaglandins, and that's pretty much it. And remember, within the prostaglandins ideally you want to suppress just the ones produced during the inflammation and not the constitutive ones which are produced physiologically to protect the stomach mucosa and for example the kidney when it's confronted with situations of poor perfusion. And that's where COX-2 selective inhibitors really come handy, as we will see later. So what are some general considerations that we should probably remember with regards to this group of drugs? As I just pointed out, they're weak anti-inflammatories compared with the steroids, but that in of itself may be a good thing because we can use them for post-surgical pain without really influencing the regeneration or healing of those tissues, and they are not actually a strong immunosuppressant either. Which is a good thing because we need those white blood cells to come up and clean up all the dead tissue and debris that we leave on surgical procedures. And when we use them, we are actually getting basically the antipyretic, the analgesic, and the anticoagulant effects. And when we talk about the anticoagulant, we're basically preventing the platelet aggregation. And this last effect is actually taking place as long as the drug is on board, because they actually work in a reversible manner except for aspirin. Aspirin actually works by binding to the cyclooxygenase in an irreversible way. So basically, as long as the platelet stays around for 8 to 11 days, it is basically non-functional. Whereas with the other NSAIDs, basically they need to be around to have that anti-coagulant action. Now with regards to the adverse effects, the one thing to worry the most by far and ahead is the ulcerogenic effect on the stomach, and this happens because we're suppressing the prostaglandin E, which is necessary to produce that mucus layer which protects against the acid. And there is this one drug which is called misoprostol, which is actually an analog of that prostaglandin E, which is basically recommended to replace that prostaglandin if we were to cause an ulcer in the stomach. Obviously, we could always give some other type of anti-ulcer medications like omeprazole or ranitidine, which basically prevents the acid formation. But ideally what we would like to do is replace the production of that mucus layer which protects the mucosa against the acid, which has been basically wiped out by the NSAID. Now the other concern is that renal papillary necrosis, which should be always in the back of the mind of anyone treating patients with any NSAIDs. In reality, this is something to worry about when the kidney is under poor perfusion, as I say, and it needs those compensatory mechanisms of the prostaglandins to maintain that blood flow to the renal papilla. And this problem can happen with both the COX-1 and the COX-2 inhibitors. And as I say, they tend to be situations when the animal may be undergoing some kind of hypotension on that kidney. Now the other adverse effect is the platelet aggregation, and that can make that animal prone to bleeding. And this is something to keep in mind if you were to perform surgery on that animal. So it may be wise to basically withdraw the medication a day or two before you perform the surgery. And finally, there are some rare adverse reactions that nonetheless could be quite serious if we were to, for example, give carprofen because it's been linked with some idiosyncratic reactions on dogs that destroy the liver. And there is another drug which we'll see is phenylbutazone, and there's some reports of bone marrow suppression. As I say, these are really rare situations, but for example, with phenylbutazone, they're the reason why FDA decided to withdraw approval for dairy cattle. Now, the other important considerations for this group in general, if a drug is COX-2 selective, tends to depend on the species. You cannot really extrapolate these between species. You may have a COX-2 selective for the dog, but it may not be so for another species. Also, because there is tremendous differences in metabolism, you cannot really extrapolate doses between drugs and between species. Also, you cannot really mix drugs in this group. If one doesn't control pain, you can switch to another one. The fact that one doesn't work doesn't mean that another one may not do the job. So that's also something that you might want to consider when you have an animal on long-term medication with one of them. And finally, when it comes to talk about washout period, this basically refers to what time frame you should respect if you decide to choose a different drug. There is no consensus. It's still a controversial area, and usually if you think that in 3 half-lives you have eliminated about 87% of the drug, that would probably be, you would have to look at the half-life of that drug and kind of work out how long that is. But usually with these type of drugs, they tend to have a very short half-life, so it doesn't work out to be more than 2 or 3 days for most of them. Probably meloxicam would probably be the longest one that has a kind of a half-life of about 21 day in most of the species. But you would kind of have to, kind of work it out for each one individually. And the final thought would be that you don't probably want to mix NSAIDs with glucocorticoids. That's definitely a no-no, and you kind of be rolling the dice to get a gastric ulcer if you mix those two categories of drugs. So in the next video, we'll probably address specific information for each one of the NSAIDs. So until next one, be well and take care for now. Bye-bye.